For a wonderful talk. And carrying on forward, now we move on to the next very interesting talk by Dr. Claudio Ronco. I feel very humbled and privileged to introduce such a distinguished and learned speaker. Dr. Claudio is a senior lecturer and full professor at University of Padova, working at the International Renal Research Institute of Vicenza in Vicenza, Italy. So he is a nephrologist and at University of Padua, and is director of the laboratory of the RRI and the Beth Israel MC New York, and professor of medicine at the Albert Einstein College of Medicine. He has published amazing number of research and books, including more than 1,600 papers, 95 books, and 205 book chapters, and delivered lectures all over the world, around more than 900 lectures. His H-index speaks for itself. It is 129. He has been editor-in-chief of 3 major journals like Blood Purification, Contribution to Nephrology, and Cardiorenal Medicine. And he has received multiple international awards. And he is the leader in the area of nephrology, including peritoneal dialysis and critical care nephrology. He has also invented the first CRRT machine for the neonates. That's amazing, called by the name of Carpedium. That's a cardiorenal pediatric dialysis emergency medicine. And this machine has saved hundreds of lives. And he's also founded the International ADQI Consensus Group and the International Renal Research Institute of Vicenza, where many international fellows have been trained. So it's really an honor and privilege to have you here, sir. And we would be very honored to listen to you. So you have the next approximately 20 minutes, and then we can have few question and answers at the end of your talk. So please, sir.
Well, thank you very much. I am really honored to have been invited to speak about extracorporeal therapies for cytokine release syndrome. These are my disclosures, but beyond this, I must disclose that in spite I've several times worked in the area of pediatric nephrology. I'm not a pediatrician, so I'm an adult nephrology. The other thing is that in this meeting, where many experts on pathophysiology of cytokine release syndrome, I feel like a boy fixing cars versus a cardiac surgeon in the fact that I'm mostly presenting mechanical possible solutions to a very complex pathophysiological syndrome. Now, probably I don't need to go into many detail because cytokine release syndrome has been the topic of the conference, and therefore it is clear that the definition of a rapid release of cytokines into the blood from massive T-cell stimulation is very clear to everyone, as it is the fact that the effect of cytokines becoming endocrines and spilling over into the circulation may actually lead to a number of signs and symptoms that may configure a multiple organ dysfunction syndrome. It is well known what are the triggers, and the fact that once activation of cytokines has taken place, this cytokine may trigger a further reaction which activates a sort of positive feedback with further cytokine release. We have already known this in the past, studying the macrophage activation syndrome and the hemophagocytic lymphohistiocytosis with the specific H score, clinical criteria, and knowing the high mortality. And in this occasion, the term cytokine storm was often utilized interchangeably with the cytokine release syndrome. While they have a similar clinical phenotype, however, their characteristics are different, and when occurring as a result of a therapy, cytokine release syndrome may be delayed until days or weeks after treatment. Immediate onset cytokine release syndrome, or severe cases, are defined as cytokine storm that we as adult nephrologists are often seeing, especially in the setting of ICU. As I mentioned before, CRS occurs when a large number of macrophages or monocytes are activated and release inflammatory cytokines, which in turn activate more white blood cells in a loop of inflammation. At this point, it is important to note that this can occur in a number of infectious and non-infectious disease, including graft versus host disease, acute respiratory distress syndrome, sepsis, hemophagocytic lymphohistiocytosis, and viral infections, including SARS-CoV-2 that recently we learned more about. And of course, patients may have really fulminant syndromes in this situation where serum biomarkers of cytokine release syndrome are definitely elevated. There are several grades of severity, and I think we are specifically interested with our extracorporeal therapies in the area of life-threatening situations. Specifically, conditions with uncontrolled CRS can be defined as sepsis, septic shock, severe viral infection, and these are the therapeutic procedures that we propose in these patients. As you can see here, we're talking about an extracorporeal blood purification technique. What is, for example, the rationale in the sepsis cascade? Well, after invasion of bacteria from in the host and activation of endotoxin and recognition by the CD14 receptor, further problem occur when activation of NF-kappa B and activation in the nucleus may lead to overexpression of humoral and cellular effectors, leading to damage to the microcirculation and subsequently to different organ damage. Now, in this situation, extracorporeal therapies, contrary to drug, can be specific, for example, in trying to remove circulating endotoxin, or can be aspecific in trying to achieve some immunomodulation when the immune system is dysregulated by removing cytokines. And finally, we can also support organ failure due to the different possibilities offered by extracorporeal therapies. In sepsis, as you know, the insult follows with triggers that can be pathogen-related or damage associated, and sensors of the host immune cells may actually go through different pattern recognition receptors that may enhance the importance of these two PAMPs and PAMPs molecules. Among the pathogen-associated molecular patterns, endotoxin is one of the most important, and it is clear that mortality is strictly correlated to the level of endotoxin in septic patients. For this reason, the idea that endotoxin is the trigger and correlates with mortality leads to the rationale of removing endotoxin well before the monocytes and macrophages may actually come to the activation of the cytokine cascade. And this can be done with a simple extracorporeal circulation through a sorbent device, which has been specifically designed to absorb endotoxin. And it has been demonstrated to work both in vitro and in vivo, removing a significant amount of endotoxin. In vivo, several studies have shown an improvement in SOFA score in severely ill patients. And in this study that we carried out several years ago, we also found 28-day survival difference, although the study was not designed to define a difference in mortality. So the problem, however, is that when endotoxin cannot be fully removed, the cascade may progress into a pro-inflammatory syndrome due to different mediators, but also after innate immunity as a response, there might be the response by the adaptive immunity, which creates a sort of antagonism. And therefore, while inflammation is a necessary evil, we have also patients that have problems related to excessive immunosuppression. And here are two cartoons designed by Hotchkiss several years ago that show that the innate immunity may lead to overwhelming inflammation, and patient may even die late with intractable inflammation, while the adaptive immunity may not be sufficient to counteract in this situation. However, there are patients in which the adaptive response is overwhelming, and you have made late deaths due to persistent immunosuppression and recurrent infections. So if we consider that the sequence of cytokine release can be theoretically pro-inflammatory and then anti-inflammatory, we could somehow figure out a sequence of potential targets for extracorporeal therapy to achieve immunomodulation. However, we have seen that the sequence not always is respected, and we have bumps with pro-inflammatory mediators and then anti-inflammatory mediators. And in some cases, there is a spillover into the circulation of both inflammatory and anti-inflammatory mediators. Now, our peak concentration hypothesis suggested that if I can remove enough concentration of cytokines that are circulating to lower the peaks of both pro and anti-inflammatory mediators, I may somehow restore a kind of immunohomeostasis in the patient, reducing the level of dysregulation. Unfortunately, these molecules are in a molecular weight range that very often cannot be removed by classic dialysis membranes. And as you can see, in spite of the improvements in permeability of extracorporeal membranes, we have seen that basically the removal of these substances is very limited. At this point, compared to classic diffusion and convection mechanism in hemodialysis and hemofiltration, we suggest the use of hemoperfusion, enhancing the possibility offered by adsorption. And in fact, sequential extracorporeal therapy in sepsis is based on the idea that the patient may have increase in concentration of specific molecular targets that can be removed by different extracorporeal tools and devices. So, for example, infection, endotoxin, removal of endotoxin, immunodysregulation, cytokine release, adsorption of cytokines, organ damage and dysfunction, organ failure, organ support. Now, hemoperfusion done by adsorption is a technique which has been known for many years. However, in the past, there were many problems related to the incompatibility of the sorbent. Today, we have sorbents that are highly biocompatible, and they overcome the limitation of dialysis membranes. They are potentially selective on the process of removal, and you may place, as you can see here, the sorbent in contact with blood. Of course, the requirements are hemocompatibility, mechanical strength, no fooling or clotting activation, and well-designed cartridges. And as you can see here, you can put the sorbent in series with the dialyzer, both in a pre or in a post configuration. And here are some examples of how we use the different sorbents. And as you can see here, there are no problems of altered pressures in the circuit that are maintained stable over time. We have also a wide spectrum of sorbents for hemoperfusion. This is the case, for example, of the nitromicropolus resin and ion exchange resins and immunoadsorption resins provided by Jaffron in China that have made possible to tackle different potential pathological situations. For example, the HA330-380 cartridges has been indicated for sepsis, burns, trauma, cardiac surgery, ARDS, and pancreatitis, and also have been used in association with extracorporeal membrane oxygenation, where the cytokines are released due to the contact with the artificial surface. The resin has been shown to be very effective in removing cytokine and very highly biocompatible. We have studied this biocompatibility in specific experimental devices that we designed for this study. And as you can see here, there was practically no different in static and dynamic conditions in terms of viability of the monocytic cell line, no difference in apoptosis, and no difference in necrosis. So the material is strictly biocompatible and can be used. The other option is to test if the cartridges are fully utilized for blood perfusion. And so we use a CT scan study to perform specific flow dynamic analysis, and we have seen a complete utilization of the cross-sectional area of the device using different cartridges. Now, one of the first point is to make sure that the sorbent does exactly what it claims to be doing, especially IL-6 elimination. And in septic patients, there was a significant reduction of IL-6 levels versus no reduction in the control group, for example. This is another patient.
Actually, I'm not able to connect the headset.
This is another study in which removal of humoral mediators also is followed by an effect on survival of septic patients treated by hemoperfusion. And you can specifically see that there are no variation in the blood parameters, while there is a hemodynamic stability in the treated group, with reduction of interleukin-8 and interleukin-6 in 3 subsequent days of treatment. Once again, the important aspect is a reduction of length of ICU stay and improvement of SOFA scores compared to the level at admission. In this case, hemoperfusion was combined with high volume hemofiltration to provide also kidney support in septic patients. And once again, the reduction of IL-10, IL-6, and TNF-alpha were evident. Now, one of the applications that we used recently to test this hypothesis has been the SARS-CoV-2 infection that fundamentally was similar to MERS and SARS, where we had matured some experience as well. We have described in Lancet last year the different mechanisms that are affecting the kidney, for example, but different organs in SARS-CoV-2 infection. And beside all the other known mechanisms, you may see that the systemic release of cytokines represent one of the important aspects leading to endothelial dysfunction and kidney damage. And in fact, increased level of inflammatory mediators in plasma of patients with COVID-19 have clearly demonstrated this concept. And more than that, it has been shown that patients who develop this pro-inflammatory syndrome tend to present a specific level of mortality. So different treatments have been listed by the speaker before me, so I will not go into these details. While blood purification techniques have shown ability to remove cytokines and have shown that standard extracorporeal therapies like dialysis is not effective, plasma exchange may be. At this point, we published on potential mechanism of kidney damage and on the potential effect of cytokine removal preventing the cytokine release syndrome induced organ damage, which are well known not just at the kidney level, but at the level of different organs, including the interaction between organs that may lead to specific damage. Now, in this situation, as you can see here, cytokine removal may represent one of the cornerstones in severely ill patients. And we published very early, February 6, 2020, before the World Health Organization declared the pandemic, that we had to prepare for extracorporeal organ support in intensive care because it was not possible to anticipate the extent of the epidemic. We knew that these patients were presenting with different syndromes, including gastrointestinal syndromes and cardiorenal syndromes. And therefore, we knew that our extracorporeal organ support system might have been of help in supporting different organ conditions. That's why we published this paper in Nature on kidney involvement and the rationale for extracorporeal therapies. And basically, you see that the viral infection leading to pneumonia and aggravated in some cases by the presence of ECMO and mechanical ventilation may lead to a systemic cytokine release with endothelial dysfunction and organ failure. Now, in this phase, as we meant before, there is an overwhelming inflammation. In this case, there might be an overwhelming immunosuppression, but in both cases, you may actually try to block this type of immunodysregulation using an extracorporeal hemoperfusion, very simple, placing the sorbent in line with the blood circulation, or in combination with the dialyzer, as described in this slide. And this has been used in several different occasions during SARS-CoV-2 infected patients. This is a typical case of a patient admitted with fever, hypotension, respiratory failure, high level of cytokines, hyperinflammation, treated with hemoperfusion for 3 days, leading to hemodynamic stabilization, normalization of cytokine levels, decrease of inflammatory parameters, and improved pulmonary exchanges. But not only that, we also found the specific biological effects, including reduction of cytokines, improvement in mean arterial pressure with reduction of requirement of noradrenaline, and specifically at the monocyte level, a sort of resolution of the immunoparalysis with restored capacity to respond to incubation with LPS and increased phagocytosis. And more than that, an improvement in the capacity of antigen presentation as demonstrated by the expression of HLA-DR on the surface of monocytes and the number of monocytes expressing HLA-DR. So there are several studies that have been somehow presenting this concept. This is one of the typical example where you can see that there is an improvement in patient oxygen saturation trend. There is also a expert review and recommendation on this concept that has led to the suggestion of utilizing extracorporeal therapies, including cytokine removal, as a cornerstone for the immunodysregulation and the cytokine release syndrome in these patients. We also did an acute disease quality initiative conference on guidelines to manage AKI and COVID-19 patients. And we published this report on Nature Reviews Nephrology, where hyperinflammation is considered one of the specific targets. And again, hemoperfusion is representing one of the possibilities, together with the possibility of removing endotoxin in patients that have a superimposed bacterial infection. So basically, the sepsis-like syndrome that may occur in COVID-19 suggested that you can use different extracorporeal organ support therapies that may represent an important part in the response to COVID-19. The question that arises was the potential and biological rationale for using extracorporeal blood purification in patients with COVID-19. Well, they have shown to remove cytokines, DAMPs and PAMPs, including endotoxin and circulating viral particles that are the triggers for the entire syndrome. More than that, it's important to consider which techniques, and hemoperfusion was considered probably the highest score for capacity to remove these substances. So the ADKI-25 on COVID-19 suggests different levels of approach depending on the stage of disease, on the pathogenesis of disease, on the treatment aim and the target for removal. And as you can see here, molecules such as cytokines represent a real target for extracorporeal therapies. So this seems to be a promising therapy. Patient selection is important. The phenotypes of patients are very different, and we need to clearly identify the right patient with the possibility to use specific biomarkers and achieve a level of biomonitoring that, despite the previous speaker said that in 24 hours can get a very good panel of cytokines, we will need a faster possibility to monitor these patients, because we need to start early. Probably we need to change filter frequently because they may be saturated very easily. And for the moment, we need to follow the clinical status, monitoring adequate anticoagulation, and waiting for further evidence on physiological and patient outcomes. One last comment is about the use of cytokine removing techniques in patients with extracorporeal membrane oxygenation. As you can see here, the sorbent circuit can be placed in parallel with the ECMO pump, and this has been actually done and studied in different situations, also in COVID-19 patients, where significant reduction of circulating cytokines were found compared to patients who simply developed ECMO therapy and high level of cytokines. And here you see that there is a high incidence of AKI, with AKI requiring renal replacement therapy in patients undergoing ECMO. And there is an estimated increase in mortality in these patients. So the possibility to prevent AKI associated with high level of cytokines represent an important aspect. We can integrate the circuit in a CRRT device, so there are no need for changes in the extracorporeal circuit. It's technically easy, is feasible, safe, and it might be effective. We need more studies to clarify this point. Certainly, in the patients that have been treated so far, and there is a larger study going on, you can see here a significant decrease in interleukin-6 that may be one of the triggers for AKI development. Combining HP with ECMO makes sense because we are at the level where cytokines are also produced in response to a bioincompatibility of the circuit, and cardiogenic shock or post-cardiac arrest can be a good indication, as well as ARDS or viral infection. Also, we need to know that ECMO is a trigger itself, and therefore elevated IL-6 may represent a target for this therapy. And this shown that this has been utilized worldwide. Increasing utilization in those patients where the CT scan shows very poor capacity of oxygenation. And there are studies, this is a case from Russia, for example, where reduction in interleukin-6 also displayed an improvement in mechanical ventilation effectiveness, or in this case, Dr. Natachai, that used the HA380 for hemoperfusion in patients intubated, displaying a significant improvement in PaO2-FiO2 ratio, which represents an important physiological target for this patient. AKI is common in patients who need ECMO, so it makes sense to prevent the occurrence of AKI, and blood purification techniques are available in this patient that may have an impending cytokine storm. I think there is a pathophysiological rationale for using hemoperfusion both in COVID and other pathological conditions with cytokine-induced hyperinflammation syndrome. Cytokines represent a possible target molecules, and studies should evaluate criteria for initiation. What I meant before for biomonitoring, we need to have biomarkers to trigger the application of these therapies and to monitor the effectiveness. And the suggestion is to identify patients who possibly benefit, start early, and monitor inflammatory parameters. One last comment about the possibility of using cytokine removal techniques in patients with CAR-T treatment or patients with cancer with specific therapies where the inflammatory level has been significantly reduced by the application of extracorporeal therapies. And here you see in particular reduction of CRP, IL-6, dopamine, and improvement in SpO2 FiO2 ratio in these patients after the procedures. In children, of course, you need to ensure the effect of blood purification while maintaining stability of hemodynamics. And for this reason, you need reduced cartridge with reduced priming volume, slower blood flow, and possibly using blood or blood products for priming. Nevertheless, we have today available pediatric cartridges for this opportunity, which are represented by cartridges that can remove the toxin and cytokines, or can even improve liver function by removing significant amount of bilirubin and bile acids. As you can see here, the size of these cartridges are significantly reduced. So we offer a new clinical option for children. There are contraindications in case of allergy to the sorbent material, which has never been documented so far. And the other are possibility of bleeding in the use of anticoagulation, possibility of hypotension or anemia due to severe systemic infection that may be further aggravated in some cases by blood leaks, although this is a very rare complication. Thrombocytopenia is also an important aspect to monitor. So in conclusion, I think that adsorption represents an interesting option for blood purification in patients with COVID-19, but also in any other type of cytokine release syndrome. Different sorbent materials are available, and modern chemistry can help because of optimal biocompatibility. Also, the possibility to functionalize the beads and create a specific adsorption, as in the case of cytokines or endotoxin. We can test this through specific isotherm, and we have different options for different circuits for utilization of sorbent in practice. And sorbents may represent the new frontier in extracorporeal blood purification technique. With this, I thank you very much, and I hope I'm not being too long.
Thank you so much, Professor Claudio, for such a wonderful talk. You have taken us through a lot of evidence and the benefits of the use of the extracorporeal therapy, which is you have clearly shown that it does benefit in the outcome related to the duration of hospital or ICU stay, decrease in the SOFA score, improvement in the cytokine markers, and probably in mortality. And also, you also took us through some of the pediatric literature and how the innovations have helped. And we have seen that now we do get these filters by Baxter and Fresenius, which were not earlier available in India, but they are now. But not easily, but we do get those. And we are now started using the, maybe the frequency has started increasing in pediatric patients, both in septic patients and COVID patients had made us more knowledgeable or experienced in this. There are few questions on this. Due to shortage of time, I'll just take a couple of them. Important one is that, like we all know, the benefit is definitely there, which you have shown. Important is the timing, when to start this. Do we have any of these clinical or biochemical markers which will say that the patient will really benefit when you start these therapies?
Well, as I mentioned before, we have this dilemma on when to start and how to perform and when to stop. And we have three dimensions that can help us. One is the chemical dimension. This is what typically we use for dialysis when there is an organ dysfunction. For example, we measure urea kinetics to define how much is the need for dialysis, how much efficient is the system to remove urea, and so on. But this is of little help in this complex syndrome. Then we have a clinical domain dimension, which has been the ones that has made clear the rationale for application, because we all know now that after a few hours we apply these therapies, patients improve the level of hemodynamic response and the endothelial response, and require less noradrenaline and improve myocardial function and tend to improve diuresis. And also, finally, they have a better general clinical response with improvement of SOFA score. The third dimension, which is the crucial one, is the biological dimension, and it would be the measurement of cytokines. However, measuring cytokines here and there does not make too much sense, because the half-life of these cytokines is so short that you may find peaks and valleys, and you have hard time to interpret the data. So one of the important aspects, in my view, would be to make available the panel of cytokines, which should be made available at the bedside, so that we can have it as a point of care to guide our therapy. And two main messages are required. One, are we in the hyperinflammatory or are we in the immunoparalytic situation? The other, are we in conditions with high peaks of these substances so that our extracorporeal therapy makes sense? For today, our extracorporeal therapy is totally aspecific. So somehow it acts on the concentration of those cytokines that are at the highest level, trying to re-equilibrate a level of immunohomeostasis. In the future, when we have the biomonitoring available, we can also functionalize the sorbent in order to specifically absorb this cytokine or the other one. So I think it's a story that is developing. As you have seen, we have now different sorbents. We have polymyxin B, we have cytosorb, we have Jafron cartridges, and it is very important to go on with research, because I think it's a very, very promising approach.
Thank you. Thank you so much, Claudio. There are loads of questions in the Q&A and the chat box. So due to shortage of time, can I request you if you can reply to those questions in the chat box or in the Q&A box?
I can certainly do that. And I would like just to ask your permission to share for a moment this slide, because I think people might be interested. We are going to have our CRRT and AKI meeting in June in Vicenza, and we will discuss a lot about these topics that we have discussed today. So in case you're interested, please write to me or contact our organization, because I think we have also a pediatric session, and it might be helpful to expand the discussion we had today.
That's awesome. And if you can also put information about this on the chat box, it will be useful for everybody. So that will be great.
Okay. Okay.
Yeah.
Okay.
Thank you.
Sure.
Thank you. Thank you so much, Claudio, for your time. It was really an honor listening to you. Thank you so much.
Thank you.